So thank you, Dr. Nagraj Desai. It's indeed a great pleasure, and I'm delighted to participate in this program organized by the Karnataka API ICP chapter. So for the next 15 minutes, I'll be talking on hypertension, new facets, looking behind the number game. All of us know the numbers of blood pressure are very important and crucial in hypertension. And World Hypertension Day 23 has rightly emphasized on accurate measurement of blood pressure, its control for living longer. And the guidelines cover the number game with great precision and perfection in terms of diagnosis, initiation of treatment, and targets for BP control. But I'm not going to bore with these numbers of blood pressure because you have heard it so many times. But behind the number game, there are a panoply of facets which are important and are of great interest to a clinician. So the first issue I'm going to discuss is all of us realize that the mortality in a controlled hypertensive is 2 times compared to a normotensive, which means you're a hypertensive patient, your blood pressure is controlled, still you do not become equivalent to a normotensive person. So let's see what are the reasons for this. The first and the most important reason is that atherosclerosis continues unabated even in a controlled hypertension, which means even if your blood pressure is normal, you are not immune from acute myocardial infarction, you are not immune from a stroke. Antihypertensive agents, they decrease blood pressure related complications, which means they will decrease left ventricle failure, they will decrease stroke, dissection, and so on, but they do not provide atheroprotection. And this was very, very elegantly shown by the HOPE-T trial, which was carried out in intermediate risk patients. CV went 1% per year, and you can see when hypertensive patients were treated with blood pressure medications only, Kentisartan 16 plus SGTs in this, you can see there was no significant change in the primary endpoint of cardiovascular death, MI, or stroke. But when the same patient was given only 10 milligram rosuvastatin, there was a statistically significant reduction of 24% in the primary endpoint of cardiovascular death, MI, and stroke. And if you remember Ascot LLA, 10 milligram of Torvin hypertensive patient, total cholesterol less than 250 after 3 years, decreased non-fatal MI and fatal MI by 36%, significant. The other reason which is now being increasingly recognized is that fibrosis occurs in different parts of the cardiovascular system. And this is a new illustration from a review article from a hypertensive. You can see that hypertensive heart disease is no longer considered as a left ventricular hypertrophy. There are several new facets were added: atrial myopathy, fibrosis in the major arteries, fibrosis in the smaller arteries, and fibrosis is now very easily recognized by LGE-CMR, that is late gadolinium enhancement. Fibrosis occurs in the myocardium. You can see these white spots. And once fibrosis occurs in the myocardium, this ventricle becomes more prone for development of heart failure. It becomes more prone for development of ventricular arrhythmias and even sudden cardiac death. All of us know scarring in ventricle always predisposes to cardiac arrhythmia, particularly ventricular arrhythmias, whether you are talking of a hypertrophic cardiomyopathy or an arrhythmogenic right ventricular dysplasia or so on. So scarring and fibrosis of the ventricle adversely alters the prognosis of hypertensive patient, and now we can easily pick up by LG-CMR. Fibrosis also occurs in the atria and produces atrial myopathy, and you can see the different grades of LA fibrosis on LG-CMR. And if you have a significant atrial fibrosis, this predisposes to development of atrial fibrillation and stroke. And an intelligent interventional cardiologist who performs radio frequency ablation of atrial arrhythmia always looks on the atrial fibrosis. If an individual of atrial fibrillation has advanced fibrosis like this, the probability of sustaining atrial sinus rhythm is very remote, and the procedure is not likely to produce beneficial results. Fibrosis also aorta, and if we recollect the normal compliant aorta or the big arteries, what do we have? The normal pulse velocity is 8 meters per second. And when in a normal individual, when the impulse travels from the aorta during systole, it goes to the periphery, comes back slowly and slowly, slowly and slowly. By the time it reaches the heart, diastole is already set in. This increases the diastolic pressure and increases the coronary filling. On the other hand, if you have developed aortopathy in hypertensive heart disease because of fibrosis, the aorta becomes less compliant. This results in increased pulse wave velocity, maybe to the tune of 12 meters per second. And what will happen? When the impulse traverses from the aorta to the periphery, it comes back very fast. And when it comes back, systole is already ongoing. And this produces a panoply of adverse effects on the cardiovascular system. It increases the central aortic pressure, increases LV afterload, patient may develop left ventricle failure, increase the pulsatile strain, and increase the chances of plaque rupture. There is no diastolic augmentation, no increased coronary filling, as happens in a normal individual. The issue is there any solution to minimize fibrosis? We do not have any proven agent or any large RCT, but very interesting data emerged from the long-term follow-up of the LR trial, as you can see in this slide, 2016. Significant reduction in the conduction system disease with lisinopril compared to CTD or amlodipine after 5 years follow-up, despite the fact that the blood pressures were higher in lisinopril group. And this seems to be due to antifibrotic property of RAS inhibition, and this could play a role. And certainly this will require an additional trial in future to assess the antifibrotic actions of the RAS inhibitors in hypertensive patients. And therefore, it stands to reason that when we are treating hypertension, we should not only be treating the 24-hour blood pressure, the nocturnal blood pressure, the morning surges, the blood pressure variability. We should also focus on vascular remodeling, because this remodeling of the larger arteries produces strokes like ischemic stroke. Smaller artery remodeling produces lacular infarcts and cognitive decline. The second issue, which is again very, very important, is target heterogeneity in hypertension, which means do all target organs respond in similar fashion to lower blood pressure, which means you have a hypertensive patient, you lower blood pressure, will all target organs, which means the heart, the brain, the kidney, respond in a similar fashion? So let's first look in the brain. The dicta for brain is lower is better. Lower systolic blood pressure is better, lower diastolic blood pressure. And how do we know it? This is data from the famous ACCORD trial, which compared 140 systolic blood pressure to 120. The trial was negative, but still you can see there's a reduction in the stroke, which was significant. And the INVEST trial shows as blood pressure is lowered, there is additional decrease in the stroke. So when we talk of brain, tighter BP control is important if you are not suffering from disease in the cardiovascular system or the heart. Lower is better, and this applies to brain. But when we come to the heart, the story is not the same. Lower diastolic blood pressure is bad for the heart because coronary artery filling occurs in diastole. And this is the subgroup analysis from the famous HOT study. And this shows the MI per 1,000 patients years. When blood pressure, diastolic blood pressure is lower, you can see these are MI. MI are always larger in patients with lower diastolic blood pressure. Not only this, the INVEST trial also very clearly shows as you lower blood pressure, there's a decrease in MI. But if you lower blood pressure further, say less than 80, there's increase in MI. So lower diastolic pressure, particularly the patient is suffering from coronary artery disease, you have to be cautious. If he's not suffering from coronary artery disease, it may not matter. And therefore, there seems to be a J curve for the heart in the context of diastolic blood pressure, and seems to start when you lower diastolic blood pressure below 70. And very interesting paper appeared in JACC 2016, which tried to assess the relationship between low diastolic pressure and the elevated high sensitivity troponin levels. You can see when we compare a diastolic blood pressure of 80 to 89, diastolic blood pressure 60, more than double the odds ratio of high sensitivity cardiac troponin T, equating exceeding the normal value. And this also increased the coronary event, which means if you lower diastolic blood pressure to 60 or low, the cardiac troponin levels are also increased. And this is another interesting study which showed that those patients of coronary artery disease who are revascularized, they tolerate lower diastolic pressure much better. The third issue I'm going to discuss is of increased sympathetic activity, which is now being increasingly recognized. Several publications have appeared. This is in Indian data, and you can see the prevalence of sympathetic activity is 62.42% data from India. And this is another beat survey, which is again from our own country. And what does it say? An increase in heart rate by 10 beats per minute is associated with 14% increase in CV mortality, 20% increase in the total mortality, and resting heart rate is elevated in Indian hypertensive. It correlates both with systolic and diastolic blood pressure, and sustained elevation of heart rate is an independent risk factor for adverse clinical outcomes and could be a therapeutic target. And all of us are aware of the Indian heart study. Dr. Kaul is not there, who carried out his study. Otherwise, I would like to have his expert opinion, which clearly shows that in India, the average resting heart was elevated around 80 beats per minute, both in the office BP measurement and in the home BP measurement in both the sexes. Now, this is again a very interesting data from the value trial, whether blood pressure is controlled or not controlled. If you have increase in the heart rate, there's increase in the cardiovascular events. And there are several such data from several trials. If you look at the live study, all-cause CV mortality in relation to changing heart rate, the higher is the heart rate, more is the all-cause mortality. And look at the INVEST trial. If your heart rate is increasing, you are increasing the composite of all-cause death, non-fatal MI, and non-fatal stroke. And sister study, whether you are men, whether you are women, if the heart rate increases, you can see there's a progressive increase in the all-cause mortality. Sympathetic system, all of us know, adversely affects the cardiovascular system, not only hypertension and several other factors I'm not going to detail. And sympathetic inhibition is a goal of antihypertensive therapy, we know, and produces beneficial effect in diverse ways. But the big answered question is that can we offer beta blockers in controlled hypertensive with increased resting heart rate, even in the absence of CAD-HF arrhythmia, despite lack of recommendation by God? We do not have any randomized controlled trial, but the data seems that this is likely to benefit. The fourth issue which we come across these days, all of us know isolated systolic hypertension, and generally all of us are familiar with this problem. But now what is being increasingly seen is that we are seeing isolated systolic hypertension in young, particularly those who are in the IT workers and those who have a lot of stress. The systolic blood pressure is elevated and they poorly respond to other drugs. When beta blockers is given, the response is very good. And publications are again emerging in the literature. This is publication 2016. Isolated systolic hypertension in young, old, everybody knows, people is not spurious and should be treated. So this is another facet, which is cognitive decline somehow is not paid so much attention in the treatment of hypertension. The earlier you start treatment, less will be the cognitive decline. This should be one of another important reason why treatment should be started early. And look at this cardiac study, which took a 25 years follow-up from CAD risk cardiac patients, which recruited healthy young individuals aged between 80 to 30 years and followed up mean age 25 years for next 25 years. And this showed increased cognitive impairment in middle life. The mean age was around about 50. So again, cognitive decline is a very serious complication of hypertension. Once it occurs, it cannot be reversed, and therefore This is another very strong reason hypertension should be treated early, and blood pressure variability should also be targeted. The other issue is vascular aging. And all of us know hypertension is a very important cause of premature vascular aging. There are other factors also, no doubt. And therefore, these days we can have non-invasively measurement of our vascular age based on the systolic diastolic pressure, the pulse pressure, the augmented index and pulse wave velocity and the central blood pressure. The computer calculates. So look at this individual. Chronological age is 54 and his vascular age is 57, reasonable. Look at this individual which I have shown. This is the one. The second individual, chronological age is 37, but his vascular age is 46, bad. Look at the third individual, chronological age is 54 and vascular age is 73, very bad. So hypertension is certainly an important factor for determining the vascular age. The other issue which we commonly see in the Indian context is that there's clustering of risk factors in hypertension. Therefore, while treating hypertension, we must also focus on the other concomitant risk factors which are commonly associated, particularly diabetes, dyslipidemia, smoking, and so on. And here you can see large number of hypertensive patients have more than one risk factors. And therefore, what we do to our patient is we provide this mobile number, health mobile number. And this number is 13080100070. What does it stand for? 13080, which means you maintain your blood pressure at 130/80, 100 LDL, less than 100. So you target dyslipidemia these days, preferably less than 70, because atherosclerosis stops at 70. 7 is for HbA1c. Try to maintain your HbA1c around about 7, and smoking is 0. So this is the mobile number we give to our patients to target the concomitant risk factors which often cluster in hypertensive patients. And the next very important issue is the quality of life. All of us know the treatment of hypertension is a long drawn-out process over the years. Therefore, special emphasis should be laid on quality of life. We should never forget life is not merely being alive, but being well. And our hypertensive patient should not only live, but also feel well. And while selecting drugs for treatment of hypertension in a young patient, one must be very, very cautious that it does not interfere with their sexual life. But the problem currently, particularly with the young generation, is digital intoxication has become rampant and is emerging as a big barrier for healthy life and prevention of non-communicable diseases. The young generations are busy with smartphones, WhatsApp, Google, LinkedIn, Facebook, Instagram, Twitter, Snapchat, Tinder, and so on. So what is suggested is that these individuals should undergo digital detoxification by doing a fast, not the conventional fast, without social media at least twice a month, preferably every week. The ninth issue is our dismal control rates with hypertension. As Dr. Mugunathan pointed, 10 to 12% of whatever is the figure. And the reason for this is if you want to increase the prevalence of controlled hypertensive, you have to adopt a cohesive efforts. As you can see, all potential stakeholders in hypertension must come together, achieve cohesive efforts, non-government organizations, government organizations, healthcare professionals, scientific organizations, electronic print media, social workers, but this is not seen in our country, and that's why the control rates are dismal, 10 to 12%, which is indeed very distressing. And there's an urgent necessity to increase the blood pressure control in our country. And the last issue which I'm going to discuss is hypertension pre-India. We have very effective antihypertensive agents for control of blood pressure. No doubt it decreases morbidity and mortality, but this does not decrease the total number of hypertensive patients. Therefore, aim should be to stop hypertension, and build an hypertension-free India. This is a very, very difficult task, but indeed possible. Let's see. And this can be achieved by primordial prevention. Primordial prevention means prevention of emergence of risk factors in population in which they have not yet appeared, by individuals and mass health education. And the most effective targets are the nursery kids. It is seen that if they are taught lifestyle modification, they continue to follow it in their later years of life. and the incidence of NCD is significantly decreased. Data from the familiar trial, data from the Ballast and Putsa trial from Spain, and therefore this would take several decades, but I think this should come into vogue so that we also decrease the number of hypertensive patients. Thank you very much for your kind attention.
Thank you, Dr. Manoria, for that wonderful presentation. In fact, you made my life so easy to bring out almost 5 several facets of hypertension that we would like to discuss with our patients and with the families of the patients. And I